Our first speaker today is Christina Master, MD, who is a residency cohort of mine. Tina was actually my intern when I was a senior resident, but the student has far exceeded the master. Christina is a professor of clinical pediatrics at the UPenn Perelman School of Medicine and has over 2 decades of experience in clinical pediatrics. She's board certified in pediatrics and brain injury medicine with additional qualification in sports medicine. She's a fellow of both the American Academy of Pediatrics and the American College of Sports Medicine, and each year treats over 800 children and youth with concussions in her outpatient practice. Dr. Master is the co-founding director of Minds Matter, the concussion program at CHOP that provides clinical care, community outreach, and conducts research in youth concussion. Her current research focuses on identifying objective physiological biomarkers for concussion and on furthering our understanding of visual deficits following concussion as a target for intervention for those with prolonged symptoms. Many of you will recognize Tina from talks she's given over the years, and today she's going to share with us some of the recent research and findings she's had about concussions, particularly in young children, which is a group that hasn't been well represented in the literature until now. Good morning, Tina. Thanks for being here.
Good morning. Thank you so much. I want to thank Linda and all the organizers of this great meeting for having me back. I'm so sorry we're not in person, but we look forward to the days when we can be all together again. So I'm really thrilled to share a little bit about what we're learning about concussion from our children in the Philadelphia area. Next slide. I have nothing to disclose. Next slide. I hope we'll learn a little bit during our time together about these various visual and vestibular deficits and how we can approach managing these kids as they're going back to all their activities, and a little bit about how COVID has affected us as well. Next slide. And so really we find ourselves in a world turned upside down. So this is a little bit of a mashup between the cult hit from Hamilton, the musical that really got a lot of traction during shutdown, as well as that series from Netflix, which literally does have an upside down world, which I think sometimes we feel like we're living in right now. Next slide. So when everything shut down in the Philadelphia region in March 13th, things really changed. As you can imagine, all of our concussion visits, even as we gradually reopened, were not the same in terms of, first off, volume. As you can see, comparing 2018 to 2020, the visits that we had really were decreased considerably. We were shut down really until May and gradually reopened after that. And this is through August. Next slide. In the good old days, you may remember when we looked at the concussion visits across our network in a publication a few years ago, what we found, what was interesting was that most kids seemed to present to their primary care doctor for concussion care. I think a lot of the research in the published literature was from the ER or specialty care, in particular sports medicine practices. And we started to think maybe that was a little bit of a skewed view. And it turns out that kids generally do see their primary care pediatricians first. And in particular, when we looked at those who had a CHOP medical home, because we have a network-wide electronic medical record, we found the vast majority sought care with their pediatricians first. And so that we felt was really important message to get out there in terms of making sure people were aware and knowing how best to identify and manage these kids. Next slide. And so in terms of patients versus visits, it's not just the visits that were down, but the numbers of patients were down as well. From that standpoint, both in specialty care as well as in primary care, the proportions of visits per patient also seem to be down, and not clear if that was a concern about not coming into the healthcare system to risk exposure to COVID or not having the need to come in. Next slide. And so now in the COVID era, as you can see, what was interesting to us is that we actually had many more coming into specialty care compared to years previous. So the two figures on your right are from the previous years, 2019 and 2018. And you can see in those years, primary care was a major presenting location for patients. And in the COVID era, it was specialty care. from the standpoint of understanding this, we're really not sure. We know that our primary care practices were really trying to make sure that they were able to segregate kids who were ill from kids who were not ill, and perhaps had greater referrals to specialty care as a result. We'll see if that's something that continues or if that reverts back to what we saw before. But again, a little bit of a shift during this COVID era. Next slide. What didn't change in 2020, and actually, if you think back to the last slide, we still had a similar proportion presenting to ER. And then looking at the age, sex, and race ethnicity distribution, those also remain the same. And so that was interesting that, again, we have really primarily the cohort that we're seeing is that adolescent age range that's sustaining concussions. Still primarily females compared to males. And that is consistent across, all of the last number of years in all of our studies. And then, of course, from the race ethnicity issue, we obviously have lots of work to do here in that it would appear that concussion is a white suburban injury, which we know is not the case. And so from that standpoint, disparities is something that we have to be aware of, obviously, in concussion as well as so many other things in pediatrics, and something that we're actively actually trying to look at in our research program as well. Next slide. And so one of the big changes, obviously, was telemedicine. We had already begun working on developing telemedicine as an option for our patients, but obviously COVID really shot that through the pipeline. And from that standpoint, as you can see, during that time frame between March and August, we really ramped up that telemedicine care that we provide for concussions. And we were able to provide really good access during our complete shutdown with telemedicine. Our patients reported really good satisfaction with the care there. And so you can see it's with us for now. Who knows if it'll be with us to stay? But I think from that standpoint, I think it's important that all of us really think about how we can utilize technology to help us engage our patients. So even when we're not in pandemic times and during shutdown, we can use technology to better engage our patients in their care. Next slide. And so then if we look back as to how they used to get concussions from some other work that we also published with our collaborators at the CDC, we looked at a large cohort of kids in terms of their mechanisms of injury. And so this is examining it via E-codes. And as you can see, there are some interesting differences in trends that generally speaking, the younger children sustain their injuries via a fall, and that decreased, whereas being struck by an object, probably related to sports participation and recreational activities, increases as they get older. And then, of course, motor vehicle crashes becomes an issue as well. Next slide. We examined this during the COVID timeframe as well. And then to look at sports concussions, obviously because we're in sports medicine, we also found that majority of sports injuries were in kids that were school-aged and above. That again, the non-sports and recreation injuries were primarily sustained with the younger children. And you see that uptick as you enter school and then really peak there in teenage years. Next slide. We examined this in a time of COVID and actually saw an interesting flip that basically with school and sports all shut down, especially organized sports, interscholastic sports, the most common mechanisms of injury really were now non-sports related and falls were a great proportion of the kids who were getting injured and really across the age ranges, not just in the younger kids. And so that's another way in which, things changed for us. And our sports medicine practice is a little bit different in that we will see kids with concussion with all sports, all mechanisms of injury, not just sports mechanisms. And so we did see that uptick during COVID. Next slide. And so then just to share a little bit about what Linda was mentioning, we have been interested in the fact that it's not just teenagers that we're seeing with concussions. There's a lot of literature out there in teenagers, college age students above. And so to better understand how to take care of our kids that were younger than high school age range, we really had to first start by describing them. And so this is some work that we just published this year, examining a large cohort of 5 to 11-year-olds. And from that sample, what we found was that, again, consistent with some of our previous research, the majority of these kids had sports and rec-related injuries, although it was a greater proportion in the subgroup that was 9 to 11 versus those who were younger in that 5 to 8 year subgroup. Interestingly, 13% had a history of prior concussion when they presented it to us for care. And that's also consistent with some work that we did earlier with the CDC, indicating that kids this age likely had on the order of an 8% chance of sustaining another concussion in the next couple of years after sustaining their index concussion. And then of interest also in terms of management, almost half of these kids had co-occurring medical diagnoses. And the ones in particular that we were interested in looking at were attention deficit, learning and developmental issues, vision diagnoses. And we were interested in these because obviously this may make a big difference in terms of how you might manage these kids and what might manifest as symptoms afterwards. Next slide. And so from that standpoint, we looked at symptoms that these kids were describing to us between them and their parents. And at the time, we were using the post-concussion symptom scale, which is a component of IMPACT, which is a commonly used neurocognitive computerized test that's used commonly in our region, primarily because they're based out of Pittsburgh, the other side of our state. And what we found from a symptom description of this cohort was that they had a median of 4 symptoms. Almost all of them had at least one somatic symptom, again, headache being the most common. So even in these younger children, that's the most common presenting sign. And they also presented with sleep disturbance, visiovestibular deficits. And so from that standpoint, it was interesting to us that even in this young age range, over half had visiovestibular deficits. In particular, we found interesting that our older children in this subgroup of 9 to 11-year-olds reported it more than the 5 to 8-year-olds. And we don't know if that's because those deficits actually occur more commonly in the 9 to 11-year-olds, or if they are more affected because they're doing more visual and cognitive work in school. And so again, a lot more that needs to be learned in this cohort. Next slide. In terms of the course of clinical care, what we were interested in was what was their experience for these kids with concussion? How did they interact with the medical system, and what were the features of clinical care during their concussion? And so what we found in our network was that over 3/4 had a visiovestibular assessment performed on their physical exam. The overwhelming majority had it performed when they presented to specialty care, and slightly less than half had it performed while in the emergency department or urgent care. And again, a lot of that has to do with the nature of care in our network. We've done a concerted effort at doing training across all specialties, so not just in sports medicine, but also in neurology, adolescent medicine, primary care, emergency department, urgent care. Obviously, we have lots of folks where they're changing over, in our emergency departments and urgent care. And so what we realize is that we really, need to make sure that we're really revisiting that training as we learn more, and also as we have new providers that are coming on and providing care to our kids. What we found was that over a majority, well over half, had vestibular deficits, and that the most common deficits were in gaze stability, which is the vestibulo-ocular reflex, where we have our kids nod and shake their head while visually focusing on a fixed target, and then also tandem gait. So obviously things that any clinician can evaluate. It's just a matter of knowing how to evaluate them and having the thresholds to think of evaluating them for that. In terms of recovery, what we found was that about 40% recovered in a week, and that almost 3/4 were recovered by a month. And this is actually consistent also with large group studies that have been performed in Canada, in particular the 5P group led by Roger Zemek and all of their group there, found that again, it was about a 30% rate of those who had persisting post-concussive symptoms at 28 days. And so it's comforting to know that our data is aligned with that. And so I think we're really hitting on what we can really feel pretty comfortable with as the rate of persisting symptoms in kids with concussion. A little less than half of our kids in this school age range actually received a letter for school accommodations. So we definitely have improvement that we can do there. And a little over half had documented clearance for return to play at the end of their clinical course, probably indicating that not all of these kids are returning to organized sports. Many are returning to recreational play or just general physical activity. And so it's important for clinicians who are taking care of these kids to recognize that we want to give guidance even when they're returning to recreational play and not just organized sports. And then again, we have a lot of work to do, which we made some changes already in terms of our emergency department, in terms of providing a letter of school accommodations immediately, having adjustments right away in that acute time frame really seems to make a big difference for our kids. And so we've made some changes there so that they have that in the clinical electronic support set that we have. Next slide. And then, of course, we thought we'd look even younger at our kids 0 to 4. And I think many people will ask us with a little bit of a skeptical stance, do kids 0 to 4 really get concussions? We really don't talk about that. And what we would say is that, yes, they do, based on the definition of essentially having, an injury that has forces that can be applied to the head, whether it's a direct force to the head or not, that essentially having that injury and then having some change, whether it's symptoms that are self-reported or symptoms or signs that are reported by a parent that manifest nothing else more severe, that absolutely 0 to 4-year-olds can get concussions. And so we need to be taking a look at that and making sure that we're addressing those issues. And so again, in looking at our cohort at CHOP across our sports medicine practice, the mechanism of injury was primarily a fall. And again, more common in our 0 to 2-year-old subset compared to our 2 to 4-year-old subset. But again, from that standpoint, fall is an important mechanism of injury. And for all of you injury folks out there, you have this resonate with you. Most common types of falls were from furniture, and then just tripping and falling and striking the ground, and then followed next by falling down the stairs. About a quarter were struck by object, and then the motor vehicle crashes were, again, not insubstantial, mostly as a passenger, but some as pedestrians as well. So again, lots of prevention opportunities there in this age range. Next slide. And so then in terms of symptoms in the preschool age range, I love this picture because this really kind of captures, in a picture is worth 1,000 words, what symptoms are we seeing or being reported by parents of preschool age children with concussion. And so again, what was interesting is that from that standpoint, there were a significant subgroup that basically had somatic symptoms, primarily vomiting though. Vomiting was more common than headache. And so that, again, sort of from an anecdotal standpoint among all of you who take care of kids with concussion, and especially the younger ones, will see that vomiting is a little bit more prominent than it is in the older kids. So important to remember. Sleep and emotional were definitely categories of symptoms that rose to the level of being issues with these kids in the preschool age range, but also visiovestibular. And again, really based on symptoms reported by the parents, whether they were blinking, having balance issues, and having issues with regard to tracking objects. And so from that standpoint, again, more reported in the 2 to 4-year-old group than the 0 to 2-year-old group, and potentially a combination of it occurring more, but also perhaps participating activities where it could be observed more easily by parents, such as recreational play. Some other symptoms that were not on the post-concussion symptom scale include personality changes or increased and decreased appetite. And so again, what we would say is that even though the post-concussion symptom scale is a great scale to use, it doesn't cover everything. And in particular, from an age-related developmental aspect, we have actually since switched over to the post-concussion symptom inventory, which has been used, developed and validated and used by the group at Children's National, and Jerry Joya and his group has done a lot of great work with that. Again, doesn't cover all of the symptoms, but is validated and has a version for 5 to 12. And so we would really commend that inventory to you and have you take a look at that, which is available online for free. Next slide. And so from that standpoint, looking at the course of clinical care for these kids, what we found was that actually most of these kids, a majority of them, saw care the same day of injury. Most of them in ED or urgent care, although some of them the same day of injury with their primary care doctor. And this probably reflects a concern of the potential for more serious injury in these children. And so from that standpoint, the 0 to 2 were slightly more likely to present on the same day. Most of these kids only had a few visits, so the vast majority, 1 to 3 visits, including their follow-up as well as their initial visits. Almost half had only 1 visit, and most of those occurred in the ER. And again, indicating that many of these injuries can be what we would presume would be minor injuries that have short-lived sequelae. And so from that standpoint, an interesting observation from our group. A substantial number of these kids had imaging performed, again, likely due to the presenting symptomatology and concern for more serious injury. Most of them were in the form of CT CT and the ER. But again, a number of them also had fractures on X-ray. Those that had CT or MRI findings were excluded from this study, so we weren't really able to comment on them. Next slide. And so from that standpoint, what are we doing with our kids with regard to academic adjustments, especially in COVID with the issues of hybrid and virtual learning? I think that all of you will be familiar with the fact that it's very common that our kids will have executive function, cognitive stamina issues. And for those kids, absolutely supporting them with suggestions for organizational strategies, accommodations and adjustments in school where they can take breaks. Again, we were hearing reports from our kids that the virtual learning might have been a little bit easier for them from a pacing standpoint because they were able to do a little bit more self-directed pacing than they were in person. A lot of schools adopted an asynchronous mode of learning where they could do things on their own independently and then in the group. And so that might have been helpful with our kids for concussion. And so again, helping them in particular with transition between in-person and learning might need a little bit more help from an organizational executive function standpoint. So giving them suggestions or support with regard to an assignment book or to-do lists and making sure that schools and teachers are aware, because I think they're juggling so much now in terms of these hybrid learning settings that sometimes it's easy to lose track of these kids needing a little bit of extra support. Next slide. In particular, what we found with hybrid and virtual learning is that our kids with visual stamina issues really had a lot of trouble. So again, all the time on electronic format really was challenging. And so from that standpoint, they might need to have more breaks, especially visually oriented breaks, sometimes going just audio and turning off their video, which I think is a great option to remember. Also remembering that, back in the old days, hard copies are actually good alternatives, larger font and using that as an alternative to the electronic format. And then considering blue light filtering lenses. They're very hip these days for all kinds of reasons. And there is some evidence that it may help with prolonged screen time. And so certainly wouldn't hurt our kids who are complaining of visual fatigue. Next slide. And so for younger kids in particular, what we found with regard to academic accommodations and adjustments in general, not just in COVID times, is that really the main key for them is pacing for cognitive stamina issues. What we find with the younger kids is that we like to actually schedule the breaks for them. So maybe every couple of hours rather than wait for them to recognize the need for a break, simply because that, metacognitive self-awareness may not quite be as, efficient in the younger kids as the older kids. And so trying to anticipate those needs, trying to train teachers to anticipate behavioral signs that indicate cognitive fatigue, such as losing attention or starting to have behavioral issues or having recall difficulty. So all those things are helpful all around. We definitely encourage low-risk physical activity for all of our kids, younger and older, as tolerated. We find that exercise ends up being like a rising tide that raises all ships, that we don't want them at risk for banging their head or falling or getting tackled in tackle football. But again, low risk aerobic physical activity for fun and for engagement actually also ends up being good physiologically for them as well. Next slide. And so what else is new from Top Minds Matter? And so for those of you who've been following the news cycle over the last couple of months, nothing good is happening in Philadelphia. And so we want to share a little bit about what we're learning at Top Minds Matter from our kids. So next slide. In terms of our research, as Linda had mentioned, we're really interested in thinking outside the biomarker box. Lots of folks have been looking at MRI and other advanced neuroimaging, as well as blood biomarkers and saliva biomarkers, which are all very interesting. And we do have some work in that realm as well. So we really got our start in our research program with physiological biomarkers, in particular visual ones, because you can see here from left to right, we have one of our gals who is elementary school age wearing our functional near infrared device, which we've been using to look at cerebral blood flow oxygenation. In the center, we have one of our volunteers basically being evaluated by a pupillometer, and we'll talk a little bit about that we've been learning from using that device. And then on the right is sort of the version 1.0 of the eye tracker by our industry collaborators at Oculogica, which uses an infrared camera to track both pupils. And so we'll talk a little bit about what we're learning about these physiological biomarkers next. Next slide. Pupillary light reflex metrics. We are very interested in this because we found that the autonomic nervous system is definitely a system that is affected after concussion. And we can see that in lots of different ways. Some kids will present with lightheadedness or orthostatic hypotensive types of symptoms. We found that exercise intolerance, along with colleagues at Buffalo, John Letty, is definitely affected and likely autonomically related. We were very interested that accommodation in our clinical exam was affected in concussion. And so we naturally felt that potentially pupillary light reflex metrics would be interesting. This is obtained via a dynamic infrared pupillometer. It uses a white light stimulus. We examined a number of adolescent athletes, basically pre-season and then after concussion. And we examined 9 parameters that you can see listed here, including pupil diameter, latency, percent constriction, constriction and dilation velocities. And then the T75 is the time to 75% redilation after constriction in response to the light reflex. Next slide. And so what we found was that actually all of the parameters, except for latency, were discriminatory between those with concussion and those without concussion. And you can see just here on the right panel that the AUCs are really pretty decent, with a maximum pupil diameter and the peak constriction velocity having the highest AUC and discriminating. You can see there in the left middle panel that latency did not discriminate, which you might think, we would have thought might have. That may be related to actually a function of the device, and this may reflect a response saturation effect, that the light is so bright that basically it washes out any discriminatory features. And so we're interested in looking at this with potentially a lower luminosity stimulus to see if a lower luminosity would actually then expose differences in latency in the pupillary light reflex metrics. Next slide. Of interest, there were also sex differences in concussion in these PLR metrics. This has not been reported before, actually. In healthy controls, there are no differences, and we found no differences, and that's what's been reported in the literature prior to our work. But in girls with concussion, we found that their T75, the time to redilation, was prolonged. And so again, there have been lots of speculation with regard to differences in girls compared to boys with concussion. And this may be a hint that the autonomic nervous system may play a role in that. Next slide. And other differences that we also found, that exercise, there's an effect that exercise has in healthy controls, in that those who were healthy, who had just done a practice and completed that and come and done their pre-injury baseline testing, had diminished PLR metrics. And so remember, in the concussed kids, they had enhanced metrics. And so what we found with those who were post-exercise, they were tired, and their pupils actually looked, they were tired as well. They had smaller max minimum pupil, they had lower peak and average constriction dilation velocities. And of interest, if you compare it to what's found in the current published literature, it was similar to adults with chronic PCS. So those with chronic PCS appeared to have pupillary light reflex metrics that appeared to be similar to those who were essentially physically fatigued after exercise. So probably more to be learned there as well. So stay tuned. And then again, from the standpoint of those who had an acute concussion and a history of concussion, they had prolonged latency. So again, some hints that there are some other signals that are there to be found if we investigate further. So hopefully we have more to report when we can all be together again in New Haven in the future. Next slide. Objective eye tracking. So this is one of our elementary school aged gals on her eye tracker, positioning her chin, watching a video. Usually more recently, our kids get to choose a video that they get to watch in the testing, and Frozen has been a huge hit. So all of our research assistants basically know all the words to the song by heart now, along with all of our kids. And so basically the infrared camera captures each pupil. The subjects watch the video, travel around the aperture of the monitor. Our industry company collaborators, Oculogica, just recently received FDA clearance for concussion, including in children for this eye tracking. So that's very exciting. Next slide. What's been interesting in terms of what we found is that eye tracking is a good physiological biomarker of concussion. This study actually studied both a pediatric and adult cohort, young adult cohort, and found that there were 12 metrics that basically differentiated concussed from controls with a decent AUC in both the derivation and the validation cohort. And there were 6 metrics that appear to be specific to pediatric populations. And this is of interest because all of you taking care of kids out there know that the oculomotor visual system is still developing in childhood. childhood. And so by the time you get to high school, you probably do have eye tracking that is more or less adult in nature. But prior to that, there are differences. And I think this is what makes it so interesting and potentially challenging taking care of kids with concussion, in that concussion as an injury is overlaid on top of normal neurodevelopment. And there are a lot of variations there. And so that makes our job that much more challenging, but that much more rewarding when we're taking care of these kids. Next slide. And so functional near-infrared spectroscopy. So you can see, again, there's a theme here with all of my models that are here that I'm showing you, that all of these physiological measures that we're looking at are easily implementable in school-age children. And so we've gotten kids actually as young as 2 to eye track, because it turns out frozen is compelling for even preschoolers. And from that standpoint, that makes us really excited that the measures that we're using are really applicable across the age spectrum. So obviously for adults and teenagers, but even younger. So functional near-infrared spectroscopy is a low-cost, non-invasive, portable imaging modality. And so again, it uses the low levels of near-infrared light to measure changes in blood oxygenation in the brain. And that actually ends up being a proxy for essentially cognitive workload. And so what's nice about this is that it's actually very comparable to functional MRI and also PET scanning in terms of their ability to monitor blood flow. And so from that standpoint, what we love about this is that we're able to do this in what neuroergonomics folks describe as natural environments. You're not lying in a tube, and you're not doing a resting state fMRI or a finger tapping task, but you're actually doing a real life actual task. Next slide. And so that's been exciting to us, in that we were able to use the King-Devick test, which is a rapid number naming reading card test. Many of you may be familiar if you take care of kids in sports. And so from this standpoint, what we looked at with functional near-infrared spectroscopy is that FNIRS was able to differentiate in healthy normal controls their performance on each of these cards. There's the practice card with the arrows at the top left. Then each card moving to your right, the one with the lines connecting, is a little bit more challenging. Then you can see the bottom 2 are very challenging, because the numbers are all offset and not connected by lines, and they're supposed to read them left to right, top to bottom. What we found was behaviorally, when we timed these kids on these tasks, the KD times did not distinguish between concussion and healthy controls. And that's typically how this test is used, is that you have a card time and a total time, and then you look at them when they're concussed and compare it to their pre-injury baseline. So what we found was that it wasn't that great, actually, in distinguishing our group of concussed from our group of controls. Next slide, please. What we found with FNIRS was that there were differences, and there were some interesting differences, actually. So if you look at the left panel, our patients actually demonstrate an adaptation pattern where the activation, cortical activation as represented by the oxygenation changes in hemoglobin in the blood, actually increased. So you had essentially in the controls, they had lots of activation occurring initially with the first card. And then the second and third card actually got easier, as you can see in the controls on the right, that the blue and the green were much less oxygenation extraction occurring for that second and third card. Makes us really think that what's happening is that it's kind of like riding a bike. Once you get going, it's easy to keep going. But then when you see on the patients on the left, they actually didn't have as much activation with the initial card, and each card was harder for them. Each card they had to activate and extract more oxygen, and were working harder to read each card. And so there was that reversal of the pattern from the controls to the patients. Next slide. And then the other interesting thing that we found was that when we looked at kids who had concussion and did this King-Devick reading card test, that those who were symptomatic with reading those numbers on the KD cards had greater cortical activation compared to those who didn't have symptoms. And so what was interesting was that this cognitive overload, as reflected by the increased need for oxygenation extraction during the task, actually preceded symptom provocation. And to us, it really validated everything that our kids have been telling us, that when they have a concussion, when they're performing a task, they can do it, but it's harder. And so from that standpoint, we really love that our research questions really are validating all the things that our kids are telling us in the office. Next slide. And so I think our take home for today really is that while some things have changed, some things remain the same during this unusual time of COVID-19. Please, all of you, remember that vision and vestibular deficits are really common after concussion, even in young kids. And even in young kids, they do have a visual and vestibular workload that they're managing in school. And so account for that in your management of these kids, in the accommodations, the adjustments that you provide for them in school and with regard to their activities, and especially taking into account those issues as you're thinking through their virtual and hybrid learning situations that they're in right now. And as with many things, I'm preaching to the choir here, younger kids, they're similar, but they're different from older kids. And that's partly why we all went into pediatrics. It makes it so very interesting and yet also challenges us to really up our game in terms of how we're approaching the diagnosis and the management of concussion in these kids. And then again, we're very hopeful that new technologies are really offering a lot of promise into giving us further insight about these different deficits that we're seeing in kids in concussion. And that in fact, not only are they going to help us understand these deficits in concussion, they'll help us understand them in our younger kids who may not be as able and may not have the semantic to be able to fully describe the full spectrum of what the concussion experience means for them, but we'll be able to actually capture that physiologically now and be able to tell their story for them. So that, I think, ties up my comments for this morning, and hopefully we'll have a little bit of time now for some questions. And thanks so much for having me. And I'm really excited about this great day. It's a great lineup that Linda and the group have pulled together. And so thanks for having me.
Okay, thank you, Tina, for a fantastic presentation and for covering so much information in such a short time. I know we squoze you. I have a number of questions for you from the audience. First one seems pretty straightforward. Can you define visiovestibular?
Yes. And so basically, the couple of things that we would say is that it basically is the visual system and the vestibular system. We describe the vestibular system to our patients as the system that manages motion sensitivity. And it acts a little bit like your body's Steadicam feature, right? So if you are running, your head is bouncing, but you don't generally throw up after a run because your brain stabilizes that visual picture. And so the visual aspect is very much a component of the vestibular system, but they're separate and related. And we actually have a publication that indicates that. And a great analogy that actually one of my patients gave me when I described the visual system and the vestibular system being separate but linked was that it's a little bit like that salmon ladder in American Ninja Warrior, where basically if both of them are working well, evenly and in parallel, then you make progress up the salmon ladder. But if one, is injured or not rehabilitated more than the other, that actually you fall into the water because you really need to have really good visual function to have good vestibular function and vice versa. And they're really integrated that way. And so we basically have combined that term together because of the fact that we wanted to recognize that they're separate and yet really integrally related.
Great. Next question comes from Maria Lopez, who is wondering what the name is of the questionnaire used for concussions in younger children.
Yes, I should have put that in the slide and I apologize. The abbreviation is PCSI, and my email was on one of those later slides, and all of you are welcome to email me with any questions, but it's post-concussion symptom inventory. So instead of what we described in the research, which was a post-concussion symptom scale, it's the post-concussion symptom inventory.
Great. Next question comes from Gordon Streeter, who asks, in preschool age children, how do you differentiate sleep and emotional changes due to a head injury versus a frightening experience?
Absolutely. I think that it's actually very challenging. And again, that's where we would generally say that depending on, the patient and the family, we do try and use our physical exam. I know it sounds crazy to try and do a vestibular exam on a preschooler or a toddler, but we do try. And it ends up being not so much, the technical exam that we do, for our high school athletes on the sidelines, but it really ends up being very much, what a general pediatrician concussion would do in terms of observing them. Balance is actually very commonly affected. And so even though a lot of toddlers already have that wide-based toddler stance and toddler gait, parents are able to report when there's a change from that. And so I think really the fact that there's a very dramatic change with the onset of injury, and it should have a gradual recovery component, and balance in particular is a big, I think, sign for us that generally shouldn't be a manifestation of an emotional experience that's frightening, but absolutely, I think that those are definitely difficult to disentangle and a challenge in this age range.
Great. Doug Curtis asked a question that I'm sure many people wanted to ask, which was, is there any way to get PDFs of the slides of the presentations? And the answer, Doug, and everyone, is yes. We'll give you information about that afterwards. From Ron Angoff. Parents of teens after concussions often raise questions about pre-existing ADHD. Do you hear much of that?
Absolutely. And so again, what we always will say is that anything that you had before the concussion may be worse after the concussion, although that's not 100%. And that's definitely, not like, all doom and gloom as a result. I do think that there is a lot of, after concussion where parents will say, maybe they had a little bit of a tendency towards anxiety, depression, or attention issues prior, but they were compensating well and they seemed to be okay. It didn't rise to the level of a diagnosis. And then after the concussion, that sort of tips them over. And so there is a combination of both of those things. I would also, though, just throw out there as like a little, silver lining ray of hope is that our kids who do have pre-existing ADHD or anxiety or depression, even if they have that diagnosis before and they've actually developed some self-efficacious coping skills, that actually when they get a concussion, they may do better, because we do know that concussion as an injury itself may result in attentional issues, executive function issues, and also anxiety and depressive symptoms. And if you've never had to deal with that before, and this is completely new to you, it can be very challenging. And so kids who don't have the pre-existing may have some challenges that kids with pre-existing may not have. And so there's a little bit of a silver lining, although it is definitely something that we always account for in the diagnosis and management of our kids.
All right. Next one from Laurel Shader. Have you found that there's a way to predict how long it takes the deficits to resolve?
Oh, Laurel is asking like the $1 million question, actually. So we have found that we're actually not really great at that. We've been pursuing this with our research for a while. There's some hints that accommodation from our work, which is a measure of single eye focusing, which probably reflects autonomic, involvement in the concussion, does seem to predict and correlate with recovery, that those who have really bad accommodation take longer to recover than those who don't. And so that's one area. A very high symptom burden from studies from other folks generally just seems to correlate probably with more symptoms being more severely affected, and that correlates with a longer recovery. But again, there's nothing that's been a real slam dunk with any of the clinical measures yet. We're hopeful that actually some of our physiological measures may be promising. And there's other work that others are doing with regard to the blood biomarkers and imaging as well. But none of them are really quite ready for prime time yet. So the best thing that I would sort of point you towards is Roger Zemek's 5P article that came out in JAMA a few years ago that basically found a combination of clinical features, being over 13, being a female, and at presentation having sensitivity to noise and having balance deficits predicted persistence of symptoms at 28 days. So I would commend you to that paper.
Okay. Tina, we have like 2 minutes left and 3 questions. So let's try and do like 2 super fast in a minute, and then we can sort of send things to you afterwards to check. So first one is, what specific advice do you offer in regard to screen time from Amy Evans?
Absolutely. What we will talk about is that the first 48 to 72 hours are kind of a golden window after injury. Try and really shut things down for that first couple of days to give your symptoms a chance to recover and your brain to recover. Then after that, it is an issue of gradually going back to your normal levels, whatever house rules are, whatever school requires and needs of you, with lots of pacing breaks, and just recognizing that you don't want to cause your symptoms to really spike high. It's okay for symptoms to go up a little bit, take a break and have them come down again, and then go back and do the activity, have it come up a little bit and go back down again.
Okay. And then maybe we'll save the visiovestibular question afterwards so we can send the answer to people. But in 20 seconds, do you like the impact test?
So we actually don't use it as a routine part of our care. It has a place for use, and a lot of schools use it. It has to be interpreted in a context and not alone. And there are a lot of variables that can affect it. If you're hungry, tired, thirsty, or just broke up with your girlfriend, it can give you low impact scores, not just a concussion.
All right. Thank you so much, Tina. We really
Thanks so much
appreciate
for
it.
having me.